Hello everyone, I'm Dr. Apurva Kulkarni, consultant pediatric surgeon, pediatric laparoscopic surgeon and pediatric urologist. We are here to discuss today briefly about minimal access surgery in our pediatric population. Many people consider minimal access surgery in pediatric patients as a fad, but for me personally, it is a big boon for our fraternity to be able to do major procedures through very small incisions in these small babies with comparable results to open surgery is really quite amazing. So let's begin. So we'll discuss about small incisions having big transformations in our small pediatric patients. So what exactly is minimal access surgery? Surgery is performed through small incisions or by accessing natural body orifices comprises minimal access surgery. So in this PowerPoint, what are we going to discuss? Why the need for minimal access surgery in our patients? What are the special considerations that need to be kept in mind in pediatric patients? What are the advantages and disadvantages, pros and cons, difficulties, and what makes life easier through minimal access surgery, and also some of the recent advances that have come up in the last few years. So why minimal access surgery is so important or considered a boon by many of the pediatric surgeons? First thing is surgery is completed through very small incisions. So as compared to an open surgery, especially for some of the major surgical surgeries that we do, which require a big incision for a good exposure of the area under consideration. Comparatively, small incisions are taken, almost 3 mm or 5 mm incisions. So the same surgery can be completed through maybe 3 or maximum 4, sometimes in very rare cases 5 incisions, which are very small, 3 to 5 mm. So that itself is a very big boon. So what it results in is very less postoperative pain. Obviously, when you give a single big incision, you have to either stretch the muscle, divide the muscle, or cut the muscle. So comparatively, the pain will be more. And as compared to laparoscopic procedures or minimal access any procedure, the small incisions give very less pain. And in effect, obviously, the smaller the incision, better the cosmetic result. And because of the less pain, the patient has a faster recovery time, early mobility because of the less pain, and decreased in-hospital stay because of that. So what are the advantages of minimal access surgery? One biggest advantage is that it gives access to small areas of body, especially inside the abdomen, like the pelvis or the kidney or the gastroesophageal junction, very easily and very immediately as compared to open surgery. For example, a surgery like cardiomyotomy will require a very big incision near going up to the xiphisternum to access that area, whereas in laparoscopy, using just 4 ports, we can access that area quite easily. In laparoscopy, we get a very good advantage is excellent vision, because the telescope reaches right up to the area of interest. It gives excellent vision, and because of the latest technologies of 4K and HD and 3D, it often gives a much better vision than what you get in open surgery. Operative time is most often less than that of open surgery for 2 reasons. One is that the access to the area of interest is quite immediate when you do laparoscopy, as opposed to in open surgery, you have to cut through the layers of skin, subcute, and to reach the abdomen, it takes a little bit of time. And because of that, once the learning curve is done with in your laparoscopic surgery, if you get the finesse of suturing with laparoscopy, your operative time decreases rapidly for the same surgery as compared to an open surgery. Another important advantage is you require at the most 2 assistants sometimes, or only 1 assistant who holds the camera is generally enough, even for advanced laparoscopic surgeries. Whereas in open surgery, you require 2 or maybe 3 assistants to retract the abdomen and 1 to hold instruments. So that is another advantage. And what I have felt personally is in bulky patients, especially, even in surgery like appendicectomy is done very conveniently by laparoscopy rather than open surgery, because to get good exposure, you do need to retract quite a bit, and you might need to extend the incision also in some patients. Having said that, there are some disadvantages of minimal access surgery. One of them is steep learning curves. Anything that you start off, anything new, you have to learn it, and especially in pediatric patients, the learning curve can be a little more, and more so for the advanced surgeries where suturing is involved especially. If for pediatric patients, special instruments are required, especially with respect to the length, as the abdomen is small, the patients are small. So in fact, even in the pediatric population, neonates require a much smaller length, maybe 15 or 20 centimeter instruments, and the infants and little older children might require 26 or 30 centimeter instruments, whereas in adults we generally use more than this. So that is you need to customize your instruments. That can be considered as a disadvantage. A very good imaging system is generally required and helps a lot, especially for suturing and the advanced surgeries. So because of both of these, because you have to get your specialized instruments, customized instruments, and a good imaging system, the cost escalation to the hospital and to any setup is there, because of which the patient has to bear some of the cost. So cost might become a little more than compared to an open surgery. And because it's a new procedure that you're learning, in the initial phases, the operating time can be more as compared to an open surgery, especially when suturing is involved. So what are the procedures that are involved in minimal access surgery? One is laparoscopy, then there is thoracoscopy, endourology, esophagogastroscopy, and colonoscopy. We'll discuss one by one in short. So laparoscopy, there are daycare procedures like hernias and orchopexies that can be easily done. Emergency procedures like appendicectomy, torsion of the ovary, reduction of interception. This is a very useful procedure that I have found, is interception reduction. And by laparoscopy, it requires just hardly 3 ports of 5 mm each. Whereas in open surgery, you might have to give incision as big that is required for an appendicectomy. Major procedures like cholecystectomy, ovarian cyst excision, especially for cholecystectomy also, I feel to get an exposure of the biliary apparatus, you need to give quite a big incision, whereas in laparoscopy, it's just 3, sometimes even single port surgeries are done. And advanced procedures like pyeloplasty, fundoplication, ureter reimplantation, all these are now routinely done using minimal access surgery. Thoracoscopy, CDH is a very common procedure done. Some surgeons might not prefer to do this in neonates, but definitely in those patients in who it is detected later, like 6 months, 1 year, CDH repair thoracoscopy is definitely preferred. Decortications for empyema, lobectomies, lung biopsies, all can be done minimally invasive surgery. Endourology, which involves cystoscopy, but diagnostic as well as therapeutic for example, posterior valve fulguration, ureterocele incisions, laser lithotripsy of bladder calculi, digestion removal, management of reflux like deflux injection, ureteroscopy, both diagnostic as well as therapeutic for ureteric calculi, PCNL for renal pelvis calculi. Esophagogastroscopy and colonoscopy both can be used for diagnostic as well as therapeutic procedures. Like gastric esophageal ulcers, gastric biopsy, foreign body removals, varicose band ligation. Unexplained bleeding is quite common problem in pediatric age group, for which colonoscopy is very useful. Then resection of large intestinal polyps and biopsies of certain areas, certain ulcers, colonoscopy is very useful. Then what are the complications? There are some complications, especially when you start off doing these minimally invasive surgeries. There can be soft tissue and vessel injury in your initial part when you're learning. That generally you tend to try and avoid if you go slow and you do meticulously. And later as you learn, then these things tend to not happen. Shoulder pain and abdominal bloating and discomfort sort of a feeling is there in most patients, which generally resolves by 1 or 2 days. We generally advocate the patient to get mobilized as soon as possible after the surgery, and as the gas gets absorbed by the peritoneum, these side effects generally are relieved. Conversion to open surgery is actually not considered as a complication by most surgeons. I surely don't consider it as a complication. It is always explained to the patient that it can happen. But as you go on in your journey of minimal access surgery, the conversion to open also decreases. But in no way it's considered as a failure of laparoscopic surgery. And of course, in the initial phases, the operating time can be a little more as compared to open surgery. Postoperative care is quite easy as compared to open surgery because there is minimal pain, as the incision sites are very small. The incision sizes and sites are small, and the only pain is generally due to that stretching of the abdominal wall because of the pneumoperitoneum. Because of that, the recovery is quite faster. Discharge is quite early as compared to open surgery, and even parents are satisfied that the patient is not cranky. So this is a small comparison chart between minimal access surgery and open surgery. Most of the things have been discussed, like the incision size, the cosmetic outcome, the pain, need for assistance, vision, the learning curve, the instrumentation and system required, and the cost escalation. So what are the recent advances? One is, which is quite useful in pediatric population, is the SILS surgery, the single incision laparoscopic surgery. Many surgeries like nephrectomy, cholecystectomy, appendicectomy are now being done through SILS, that is a single incision in the umbilicus, and all ports are put through that incision. So it's technically a little more difficult than conventional laparoscopic surgery, but the scar is seen only in the umbilicus or just infraumbilical, nowhere else. The other is node surgery. It is not very often that we do in pediatric surgery. It's using natural orifices like the mouth and the anal opening. 4K and 3D imaging, these have now, as the technology has evolved, both of these are to be found in many of the systems available, and they are very useful, especially the 4K imaging. 3D imaging also in certain areas like the renal cavity, the renal fossa, the pelvis, and near the biliary apparatus, it is very useful. Robotic surgery is a new trend which has started. Personally, I feel there's still time to use it in the broad pediatric population as of now. But of course, in older children, like more than 5 years of age, it is very useful. But there needs to be decrease in the cost and decrease in the size of the instruments. Then robotic surgery will be more applicable to pediatric population. So where do you get to learn this minimal access surgical training. There are many centers in India and abroad where minimal access surgery as well as robotic surgery is now being taught to those surgeons interested, and as well as there are official fellowships available in both government as well as in India. So these can be done to refine your training and to get more advanced training. And because of these training centers available in India, more and more pediatric surgeons are now moving towards MAS for advanced surgeries also. So this was the presentation. Hope you like it. Thank you very much.